Okay, we are live now.
Okay. Hi, everyone, and thank you for watching our group's video debate. My name is Amanda Thompson, and I am from Ruskin, Florida, and I will be the introducer for our group as a whole this evening. Our group will be conducting an informal debate conversing the pros and cons about are restraints in seclusion ethical for people with autism and other developmental disabilities. On the pro side, Hannah Turney from South Carolina will have the role as the illustrator in stating the introduction. Mackenzie Duncan from Bloomington, Indiana will have the role as the researcher and provide the summary. For the con side, Tyra Washington from Neptune, Jersey will be the illustrator in stating the introduction, and Kristen Lubbers from Iowa will be the researcher and provide the summary on the con side. I will then conclude the debate and open us up to questions and answers. So to start off with the pro side, Hannah will begin.
Hi, Mackenzie and I will be arguing in support of restraints and seclusion as a form of intervention. Restraints and seclusion are commonly used as emergency interventions related to high rates of severe self-injurious behaviors and aggression towards others under the supervision of a trained professional with the intention of fading out the intervention. Restraint is defined as any manual method, physical or mechanical device, material, or equipment that immobilizes or reduces the ability of an individual to move his or her body freely. This can also include the use of drugs that are used to restrict an individual's movement or behavior. Seclusion is defined as the involuntary confinement of an individual where they are prohibited from leaving.
As Hannah had previously mentioned, restraint and seclusion are used as an emergency intervention built into an individual's plan to help prevent the person from causing serious harm to themselves or others. Restraint and seclusion should be administered under the close supervision of a specialist in tandem only to react to a situation when all other interventions currently do not work. Many have deemed the use of restraint and seclusion as unethical and dangerous to the individual and the staff involved. The general feeling is that it is dehumanizing towards the individual. Other people feel that it is sometimes the only option that is left to intervene during extreme behavior episodes in order to prevent self-injurious behaviors as well as injury to others in the vicinity. Most studies that discuss the continued use of restraint and seclusion note its use as an emergency procedure to prevent any harm, and that there are strict guidelines on how it is implemented, such as the specific training for staff and mandatory reporting procedures. Restraint and seclusion is not generally considered as the only intervention for severe problematic behaviors, but as a last resort procedure when a behavior episode has come to an extreme where harm may be caused to themselves or to others. As stated in an article by Vollmer in 2011, although many persons with severe behavior problems can be effectively treated without the use of any restrictive interventions, restraint may be necessary on some rare occasions with meticulous clinical oversight and controls. In addition, a carefully planned and monitored use of timeout from reinforcement can be acceptable under restricted circumstances. Seclusion is sometimes necessary or needed. Most agencies and advocacy groups are pushing for a reduction in the use of this treatment method. However, there are clinical situations for which verbal and behavioral techniques are not effective, and the use of seclusion and/or restraint becomes necessary to prevent harm to the patient and/or to staff. There have been multiple articles and studies that discuss restraint and seclusion as a single treatment and as a part of a treatment package. In a 2012 article by LaBelle, it was stated that adverse effects, injury, or death as risks associated with the use of restraint and seclusion are considered low probability but high consequence events. The probability or likelihood that someone will die from restraint procedure is low if we consider the number of restraints that are performed in a year. Furthermore, they go on to note that Individuals with Disabilities Education Act, or IDEA, emphasize the use of positive behavioral interventions and supports to address behavior that impedes learning. However, it does not prohibit the use of mechanical restraints or other aversive behavioral techniques for children with disabilities. The recommendations in the article by LaBelle propose federal legislation mandates the following rule for restraint and seclusion. If it impacts breathing, is unallowed. It is unallowed unless behavior poses a danger to self or others. It is used only by personnel trained in crisis intervention programs. The process concludes immediately on cessation of behavior, should not be written in the plan as an intervention, but as an emergency procedure only, and immediately after restraint, documentation is in place, including the notification of parents. In another study done by Banda in 2012, there was a 14-year-old boy diagnosed with autism who frequently engaged in self-injury. It was noted that in order to escape these self-injurious behaviors, the boy would engage in self-restraint behaviors, such as wrapping his hands up in blankets, and seemed to find this soothing. In this case, restraint was used on the individual towards himself, and the clinicians were able to take this method and gradually fade it out to decrease those restraint times, as well as instances of self-injury. The conclusions of the study showed that the outcome of the gradual fading of self-restraint on the child with ASD and Tourette's had the effect of lowering self-injurious behaviors to be at 0 levels. The faded use of restraints, long-term maintenance of reduced self-injury levels, and higher social validity from adults.
The following graph shows the client's SIB per minute during baseline intervention, fading out of the blanket, and follow-up phase. During the intervention phase, the subject received reinforcement on a fixed interval schedule, while SIB was ignored. He was also able to hold a blanket and wore a helmet and gloves during any occurrence of SIB. After this phase, a phase was completed where the blanket was faded out. During the fade-out procedure, a fixed interval schedule of 10 seconds was implemented, with SIB once again being placed on extinction. The blanket was systematically cut down in size throughout this procedure, and after 28 sessions, the blanket had been completely faded out.
In an article published in 2011 by Knox, the American Association for Emergency Psychiatry, Project Beta, which stands for Best Practices in Evaluation and Treatment of Aggression, reached a consensus that restraint and seclusion is necessary in certain situations in which verbal and other behavioral techniques are no longer effective, and the use of seclusion under restraint becomes necessary to prevent harm to patient staff. The consensus of Project Beta was that when the recommended procedures are followed, the use of restraint and seclusion is considered an emergency intervention and only used after other techniques have failed, and the situation may result in harm. It should be used in the least restrictive intervention possible should be considered. Knox suggests that other approaches to reduce the need for restraint and seclusion should be applied, including changes in organization culture where restraint is viewed as treatment failure, implementing an administrative quality management review process that is aimed at improving outcomes in managing aggressive behavior, regular staff feedback, early identification and intervention using de-escalation techniques, and the use of protocols or aggressive management algorithms to guide clinical interventions.
Knox and Holman used an algorithm to determine if restraint and or seclusion should be used. You can see that the answers to the questions will help guide you in determining if all aspects have been effectively considered before the implementation of either restraint or seclusion. Questions such as, is verbal de-escalation or medication administration effective? Is the patient a danger to others? Is the patient a danger to themselves if secluded? And will the patient sit in a quiet room that is unlocked? Are all questions in the algorithm.
In a 2019 study done by Peter Peterson, it focused on conducting a functional analysis and functional communication training to reduce problem behavior and reduce time and restraint. In this case, the client engaged in problem behaviors and had to be restrained by staff as an emergency procedure in order to prevent injury to himself or others. The study chose to implement an intervention, in this case SPCE, along with the functional analysis, but not altogether get rid of the use of restraint during this process, as it was still in use as an emergency procedure. Peterson noted that in the BACB ethical guidelines for behavior analysts, there are specified instances in which restraint is acceptable, such as in crisis management for dangerous behavior, when it is included in a comprehensive behavior support plan, and when alternatives to restraints have been attempted. The results of the functional analysis in Peterson's study showed that the demand condition was at the highest level, and that the client received negative reinforcement through a state of demands. Teaching FCT to the client reduced problem behaviors to near 0 level. In continuance of FCT, there was an increase in functional responses and a decrease in restraint times. Time restraint in baseline conditions was at an average of 145 minutes a week. After intervention, the average was reduced to 52 minutes a week. In follow-up, time and restraint was reduced further to 5 minutes a week.
The results of the study suggested that the use of functional assessment and ongoing functional communication training may in fact successfully eliminate and or reduce the use of restraint. The provided graph shows the relationship between functional communication training and the reduction in the rate of problem behavior and an increase in the rate of functional responses.
Referring back to the study by Peter Pedersen, levels of responding were variable in baseline phase, which reflected transitory states of severe problem behaviors, and the rates were not quite stable, which was a limitation. There was also no formal treatment integrity data collected in this study. Other limitations of the study include not having a clear consensus that staff training wasn't an additional factor in restraint reduction, and not just FCT. The possibility of measurement reactivity due to sessions being shown by another person in the room. And even this study stated that they did not directly demonstrate that time and restraint was reduced by FCT, but time and restraint was continuously measured several months prior to and directly following the intervention, which showed an overall decrease.
Next, the pro side will discuss examples of restraints and seclusion. During my time working in a clinical setting, I worked with a client that was over 5 feet tall and weighing over 150 pounds. This client would engage in self-injurious behavior in the form of headbanging against hard surfaces such as concrete floors, bricks, and walls, while also engaging in aggression towards others around them in the form of lunging their body towards staff members, biting others, leaving open lesions and bruising, and grabbing the staff members by their clothing arms or legs to move the staff member closer to make physical contact. These behaviors would be exhibited on average of 1 to 2 times per hour and lasting anywhere between 5 to 30 minutes in length each. The client was hospitalized during this time due to severe self-injurious behaviors and discharged after medication change that did not decrease his SIB behaviors to a safe level. In the home setting, the guardians would administer medication provided by the doctors and utilize seclusion and restraint to keep the individual and those around him safe. The individual had a helmet available but would not keep it on throughout the SIB behaviors, even after ongoing desensitization procedures and reinforcement during times of wearing the helmet outside of SIB behaviors. Oftentimes, the staff members wouldn't be able to physically or vocally prompt the individual to put on the helmet without being harmed or increasing the SIB. A behavior plan was created to reduce the SIB and aggression towards others, including functional communication training and a high rate of reinforcement that also included ongoing parent training and support to ensure consistency across instructors and settings. The behavior plan also included an emergency protocol for 2-person holds as a least restrictive intervention during times that it was deemed that other interventions were not effective in decreasing the SIB and keeping the client safe. With an ongoing functional communication training, reinforcement of appropriate communication and compliance with demands, and ongoing parent support and training, the use of restraint was decreased to 1 to 2 times per month, and SIB and regression towards others was reduced to 1 instance every 4 to 6 hours.
My example as a teacher working with a variety of students in a classroom setting. In recent years, I had a handful of students that showed a lot of moderate to severe aggressive behaviors, which were not only disrupting to the general education setting, but also really dangerous. In one such case, there was a student of about 10 years of age, a boy, who regularly hit, kicked, scratched, spit at other students and teachers. He would also begin to flip over tables, throw objects, sharp pencils, books, scissors at the peers in his room. Naturally, the teacher would have to clear the classroom, and then as a special education teacher, I would have to go in and follow the steps of his behavior plan. The behavior became so frequent that not only was the student receiving attention that he wanted for his behaviors, but the other students were not able to learn due to having to clear the room constantly for those disruptions. And they were all afraid of the child, which caused this specific child more isolation. We knew that we had to find an alternative while working with the teacher on positive interactions, interventions we could use for the student to promote the in-class behaviors. We needed to have a crisis plan for those outbursts because they were so dangerous. We implemented a removal system for the absolute necessity that he has become a danger to himself or others. In the plan, he was removed to an empty room, and I watched him and log data not interacting with him. during this time. In these cases, seclusion was necessary for the student to calm down, but also to be away from the other students so that they were safe as well. Restraint became necessary in the circumstances where the student would begin to attack staff members or when he began to do self-injury behavior such as slamming his head into walls. Unfortunately, the student's family moved from the corporation, so I'm unaware of his progress at the time. When we thought about his plan, no one's first reaction was to seclude or restrain the child. We wanted to support him in other ways that he needed help in. And we did all we could with that. However, seclusion and restraint became necessary in certain circumstances where the child was a danger to himself or to others. As a school, we had to responsibly keep the students in a safe environment where they could learn, including this child. In some individuals, these practices may continue to be necessary for these emergencies.
It is our ethical duty as individuals that serve such a vulnerable population to provide the most effective and least restrictive treatment possible. As stated by the DOCD Compliance Code in Code 403, programs should be tailored to the individual's unique behaviors, environmental variables, assessment results, and goals. Sometimes this means that the use of restraints or seclusion as one aspect of a treatment plan is necessary, but should also only be used if it is determined to be the least restrictive intervention as stated in Code 409.
All right, now Tyra will begin with the con side.
So Kristen and I will be arguing against the use of seclusion and restraints. Seclusion and restraints can be both physically and psychologically damaging to the adult who's performing the task and also to the client or individual who's being restrained or secluded. And due to those damages, seclusion and restraints, due to the damages they cause, research demonstrates that this technique for managing difficult behaviors is unethical and it should be eliminated.
Overall, we believe seclusion or restraint is unethical because it can cause psychological trauma, physical damage, it's expensive, and it is discriminatory. Students with autism are more likely to be restrained than students without autism, and we want to be as inclusive as possible. Aversive intervention still exists despite the strong push for positive behavioral intervention and supports. Others can justify the usage of restraint and seclusion with the need for client and staff safety, despite there being little to no evidence that these methods end in successful behavior intervention and change. Restraints are overused when other interventions should be effective if completed before resorting to restraints. Many practitioners jump immediately to a restraint before considering or utilizing a less restrictive route. Looking at the research on this, the first topic I will discuss is that autism is at a higher risk for restraint and seclusion. In an article by Weber from 2014, there was evidence to support that individuals with ASD were at risk for seclusion. The study used a self-report questionnaire, and people reported that a high percentage of the individuals they knew who had been secluded had a diagnosis of ASD. Individuals with ASD are more likely to show challenging, aggressive, and destructive behaviors than someone without, which are also risk factors for seclusion usage. Another article by Katianis talks about a stat from the Office for Civil Rights. They reported that of the 12% of students sampled who had a disability, approximately 70% were subjected to physical restraints. Students who have disabilities are 50% more likely to experience corporal punishment in schools than their peers. Next, Tyra is going to talk about a few graphs discussing the discrimination of using restraints and seclusion on students with disabilities or autism.
So according to the first bar graph that you'll see by Weber from 2014, the graph shows that individuals with autism are more likely to be subjected to seclusion and restraint, which is discrimination. So approximately 55% of individuals with ASD are secluded and about 35% are restrained. This is in comparison to the 35% of individuals with a psychiatric disorder being secluded and about 15% being restrained. So the next graph that you'll see focuses on restraint, students who are subjected to physical restraint by their disability status. So students with disabilities served by the IDEA represent 12% of students enrolled in public schools. But 75% of those students who are subjected to physical restraint during school. Clearly, restraint is not the norm for students without disabilities. So the question becomes, if other methods can be used for those children, why not with children that are autistic? The next graph will focus more so on seclusion, students who are subjected to seclusion. So students with disabilities served by the IDEA represent 12% of all students and 58% of students subjected to seclusion in school. Again, seclusion is used more with students with disabilities than with students without disabilities, and the minority group is being discriminated against.
Some limitations of one of the studies we discussed, the 2014 Weber study. The majority of the research done on seclusion has been done in mental health facilities with patients suffering from mental health issues. Because of this, there is somewhat limited research on the effects of seclusion and disability services. Our next topic we'll discuss is how seclusion and restraint can be dangerous. From StopHurtingKids.com, restraint and seclusion violates the No Child Left Behind Act and the IDEA. Seclusion and restraint are not evidence-based practices, and individual liberty is protected under the least restrictive alternative. The least restrictive alternative for each child must consider the child's individual interests, the purpose of the treatment, and the interventions and environments chosen. Interventions must be demonstrated as effective for the purpose for which they are used and must have proof of therapeutic value. Restraint and seclusion crosses the line for this a lot and does not fulfill those qualifications. More than 2 decades of peer-reviewed studies have provided strong evidence of positive alternatives for addressing even the most serious behavior challenges, including self-injurious behavior, aggression, and property damage. The goal of positive behavior supports is not merely to suppress or eliminate unwanted responses, but it's to understand and to respond thoughtfully to their cause and purpose to truly get to the root of the issue. It's important to substitute more appropriate and effective behaviors and make the child's needs known. Some reasons not to use aversive procedures is that children generalize what they learn. If a child experiences fear during restraint in the classroom, they will begin to fear and avoid the classroom in general. Also, children learn from adults. If an adult gets physical to problem solve, the child will also think it's okay for them to do that. We do not need kids mocking adults on the playground getting aggressive over minor issues. It is more helpful to seek the underlying cause of the behavior. Trusting a teacher and feeling safe at school is vital for healthy child development. All children should enjoy equal protection from danger and risk despite having a disability or a diagnosis. And children with disabilities should be taught positive strategies, which is the norm for neurotypical children. From 2011, Health and Beauty Close-Up discusses, they looked at a range of time, 2006 to 2011, approximately more than 200 students, including students with disabilities, have died due to seclusion and restraints being used in schools. In 2009, the Government Accountability Office did an investigation that reported that thousands of students have been physically injured and emotionally traumatized as the result of restraint and seclusion in public schools. Some specific cases of this, students have died from mechanical compression to the chest or smothering while they're being restrained. A school child died because he hung himself while he was alone in a seclusion room. A 4-year-old was tied to a chair as restraint and abused. Five children were duct taped to their desks as a form of restraint. And a 10-year-old boy who was put in a seclusion room 75 times over a 6-month period for hours at a time for offenses such as whistling, slouching, and hand-waving. This is clearly not the least restrictive alternative, especially for behaviors that are not truly harming others. A study from Weber in 2011 states that behaviors perceived as harmful, destructive, or disruptive are likely to result in a restrictive intervention that can impact the liberty of this disabled person. Skill development and environmental enhancements are preferred and evidence-based practices. Restraint and seclusion is debated over the clinical merits, but it's also a human rights issue because you're taking away the individual liberty. Besides physical restraint, chemical restraint is also very common, mostly using psychotropic meds. Chemical restraint is also used as a routine, not just emergency or as needed. An Australian study that reported that 5% of the people receiving an intellectual disability service were reported to be receiving chemical restraint on a regular basis, with the majority prescribed antipsychotic medication for routine use. A classification of medication as a restrictive practice in relation to behavior or as a treatment and related to a mental health problem is very controversial. A problem behavior sometimes can be viewed as a mental health condition, which legitimizes the use of medication, but it may not necessarily be a mental health condition, just the behavior we need to find the root of to make effective behavior change. Some limitations of these studies, the Weber 2011 study, there was a small number of cases of restrictive interventions, and the prevalence rate of restrictive interventions are difficult to determine. Restrictive interventions are also defined differently across jurisdictions, and data is collected differently. So while we can do some comparisons, it is not very fine-tuned because everyone in the study is talking about a slightly different procedure. Some research on the cost effectiveness of using restraints or eliminating them. From StopHurtingKids.com, there's a company called Grafton School Incorporated. It's a nonprofit in Virginia that serves children and adults with autism and other diagnoses. They have a long history of using restraints, issued a restraint reduction effort. So this was to lower the amount of restraints they were using. The CEO quoted, "Eliminate restraints without compromising employee and client safety." So he used key reduction strategies. He implemented leadership oversight and review of every event. He supported clients in crisis. He provided his staff with training, tools, and management support. So since 2004, restraints were reduced by 99.8%. So some of the benefits of this, it reduced client-related staff injuries. It reduced staff turnover, which saved the company over $500,000. It reduced employee lost time and lost time expenses. It reduced number of workers' comp claims and the cost of those claims. It reduced the liability premiums because they weren't cashing in on their insurance policy as much. And it increased staff satisfaction and staff perception of greater safety on the job. Tyra is going to be talking about a graph about the Grafton company.
So if you take a look at this graph here, you will see that there is a reduced amount of workers' comp in relation to the time spent eliminating restraints. And as more restraints are phased out, money was saved due to less workers' comp filing. And besides being safer, more ethical, and more inclusive, reducing the usage of restraints can save a company money as well. Now the con side is going to provide some examples, and I will start. So I currently work for a company that provides in-home ABA therapy services to children with autism. And from the very beginning, I was told that our company has a no restraint and seclusion policy. And in my experience at work with challenging and aggressive behaviors, I've never needed to restrain a client. I've been successful at determining the function of the behavior and being able to ease the situation and calm the client. This proves that it can be possible to have a great and safe work environment without restraint and seclusion. Now, Kristen will give you an example of her own.
The first company I worked for was simply a special needs recreational camp. It's not specific for autism or ABA. They provided restraint training. While we were trained on how to properly do these restraints, I never had to use one. Our first line defense was always de-escalating and trying to find the cause of the challenging behavior. I've never felt unsafe there, and not every employee was restraint trained, but we never had a situation where an untrained employee needed to perform a restraint. It is possible to work in an environment with individuals with autism and challenging behaviors without performing restraints.
In my example, I worked as a speech therapist in many different schools, and one school in particular that was just for kids with autism. They used physical restraints and seclusion, and it seemed to have caused adverse physical and psychological effects on both the staff and the kids. The use of restraints did put patients at risk for physical injury, and it could possibly cause death and cause traumatic even without physical injury. The one kiddo I observed, they had him like on the floor and his hands behind his back, and he was just screaming in agony. And they were trying to get him to calm down. And he ended up hitting one of the staff. So a lot of times, either the kiddo is going to get hurt or the staff can get hurt too.
So to wrap up the con side, it is our duty in the field of ABA to provide considerations regarding punishment procedures. Part A of the Ethical Compliance Codes 4.08 recommends that behavior analysts use reinforcement rather than punishment. So we just want to keep in mind that seclusion and restraint are not reinforcers.
All right. So now we are going to do questions and answers. So the first question that is a lack of training may be a potential issue for those who perform restraints. Are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints? Hannah's going to answer part of this first.
The ABA company I provide services through has mandatory training for holds and self-defense. Each staff member must be trained by a certified trainer and signed off as certified before being able to assist, call, administer any type of physical restraint. Each staff member is provided with ongoing feedback and training throughout the year. Extensive documentation and in-person review is completed with all staff members involved in a restraint situation, during which time it is discussed how the restraint could have been avoided in the future.
You should use restraints only as a last resort after attempting or exploring alternatives. Alternatives include having staff or a family member sit with the patient, using distraction or de-escalation strategies, offering reassurance, and administering certain medications. If appropriate, alternatives have been attempted or considered but have proven insufficient or ineffective or are deemed potentially unsuccessful, restraint may be appropriate. A provider order must be obtained for patient restraint. Be sure to update and revise the care of plan for a restrained patient to help find ways to reduce the restraint period and prevent further restraint episodes. To help reduce these risks, make sure a physical restraint is applied safely and appropriately. With all types of restraints, monitor and assess the patient frequently. To relieve the patient's fear of the restraint, provide gentle reassurance, support, and frequent contact. Monitor vital signs and like their pulse, respiration, oxygen to help determine how the patient is responding to the restraint.
Do you want me to ask the second question?
Sure.
Okay. The second question is, the use of restraints and seclusions vary from setting to setting. For example, is I in Indiana? Okay.
Yeah.
In Indiana, mechanical restraints are not recommended to be used for people in adult services. It is ethical to use this as a way to address behavior if it is not something that can be used across various settings. What happens if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not allowed?
So it is important to know each state and company policy regarding restraints and seclusion before either providing services and or seeking services for an individual. If it is determined that restraints and seclusion is the least restrictive and effective treatment plan for an individual, it would be important and one's ethical obligation to seek a state facility that is able to effectively provide the least restrictive and most effective treatment for that individual. So there is a list on the website where it lists each state's policy on restraint and seclusion. So that way everyone knows, depending on where, if a kid moves to a different state or moves to a different school within that state, and what the policy is for all of that. And the last question is, do you have any personal experiences related to this topic that you would like to share? And Mackenzie is going to answer that.
Yeah, so I come from the public school system background, and so we have to utilize seclusion restraint methods more in recent years than ever. It's not for lack of trying the positive methods. The issues that we face is a student becomes a danger to themselves or to the classmates or to the staff in the room, and therefore can no longer keep them in there, even if that's the best place for them. In a room with 19 to 22 other students and staff, we have to think of the other kids first and foremost, which is where seclusion comes in. We use the seclusion with ourselves in the room, monitoring but not engaging, kind of let the student calm down, monitor them for any self-injury behaviors they might have. On occasion, when a child begins those behaviors, we have to restrain them. The ideal is for these students to follow their behavior plan, which includes positive and proactive strategies to address the behaviors. We use seclusion restraint as a last resort in most cases. We are limited, though, as a school, in how long we can keep these aggressive behaviors in the room with other kids. It becomes upsetting and traumatizing to those other kids as well. We try to work these methods in as a crisis plan. Not something that we turn to do, we like to do, but we have a lot of objects and people around us, and that is the safest thing to be done for the majority at the time.
So that concludes our debate. So thank you all for watching.